I'll go ahead and introduce myself. My name is Jonathan Graff Radford. I'm a behavioral neurologist at Mayo Clinic in Rochester. I do clinical trials in Alzheimer's disease and as well as observational studies down there. And today I'm going to be talking about what's new in Alzheimer's disease. It's going to be a brief presentation, and then the point of today's talk is really to have a lot of question and answer time. And so we're going to pass around a mic box at the end of my presentation, and hopefully you all can talk into the mic box, ask your question, and we'll answer to the best of our ability. And there's a lot happening in the Alzheimer's disease space, and we're going to go over that in today's talk, and we'll go ahead and get started. Couple of disclosures. As I mentioned, I'm a clinical trialist, and so a couple of the trials that we're doing at Mayo are sponsored in part by ASI and Cognition Therapeutics through the NIH. I'm also on a data safety and monitoring board for the NIH for StrokeNet. So, as I mentioned, we're going to start by giving an overview of current treatments and then talk about some of the future approaches that we're working on to take treatment to the next level. So therapeutics for Alzheimer's disease for many, many years was symptomatic, and these were the drugs that we used to treat Alzheimer's disease, but they didn't actually modify the disease. They masked some of the symptoms of memory loss, some of the neuropsychiatric symptoms, and they did so modestly, but they didn't impact the hallmark pathology of the disease, which is amyloid plaques and tau tangles. In 2023, after 20 years of no success in developing new therapeutics, we had our first newly approved drug for Alzheimer's disease that was fully FDA approved, called lecanemab, which was an antibody against one of the hallmark proteins that cause Alzheimer's disease, called amyloid. And it's given every 2 weeks, and it got approval for the treatment in early Alzheimer's disease. So those are people who were just diagnosed, who had mild cognitive impairment or mild dementia. When they tried these drugs at later stages of the disease, they were not as effective. A year later, second drug in the class called donanemab was approved, and now we had two new drugs. You can think about the two drugs, they're pretty similar in terms of efficacy. There's not a big difference. Lecanemab is given every 2 weeks. Donanemab is given every 4 weeks. The side effects for donanemab are probably slightly higher than lecanemab, but no one studied them head to head. But those are the most inferences we can do in terms of comparing the two of them. So now I'm going to go over what these trials showed, and that's going to lead us into what's coming next in Alzheimer's disease. So the lecanemab trial was called Clarity, and it had a large number of people with early Alzheimer's disease, about 1,800. Half got lecanemab infusions for 18 months, half got placebo, and they used an outcome measure that measured people's function, so that's their ability to pay bills, their ability to cook, the ability to take their own medications, and their cognition, so their memory and thinking. And what they found is that those who went on lecanemab had a slowing of the cognitive decline of about 30%. That means the drug didn't stop Alzheimer's disease, it didn't reverse it, but those who were on treatment did have a significant slowing. And you can think about that 30% on an annualized basis, that it gives you back 3 to 4 months of preserved cognition every year. And so for us, that was a big deal because we hadn't had a successful drug in 20 years. But there were key safety issues that need to be managed. Some people developed brain swelling, and some people developed microbleeding in the brain. And so people are monitored very carefully during their treatment to deal with these issues if they occur. And we know the risk factors for developing these issues, so there may be some people who, even though they have mild Alzheimer's disease, don't get the drug because their risk would be too high. This is just a graph of what the difference is, and I show it because it's important to realize that people on lecanemab did still, on average, decline. So again, this is not a cure, it's a slowing down of the disease process. It was important because it not only hit its primary endpoint, which was this slowing of cognitive and functional decline, but they also hit all of its secondary endpoints as well. So it wasn't just it hit one out of a few of the important factors. The second trial I'm going to mention is the Trailblazer trial. So this is the donanemab trial. It had a similar about 30% slowing of cognitive decline. It was designed a little bit differently, and as I mentioned, the main difference is this drug is given monthly. But it similarly hit all of its endpoints, and both drugs really effectively remove amyloid from the brain. So at 18 months, 60 to 80% of people on these drugs have no amyloid in their brain. How can we capture what these drugs do in a different way? So one way is to say, how many people on these drugs move to the next stage of the disease at the end of treatment, 18 months? And so one way to look at that is going from mild cognitive impairment to mild dementia. So what do I mean by that? Mild cognitive impairment is when you have memory loss that's different from your memory before, but you're still able to function independently. You're driving, you're doing your finances, you're cooking. So the cognitive change is not impacting your daily function. Whereas mild dementia, some of those complex tasks become more problematic. You're no longer able to do your finances by yourself. You're no longer able to follow multi-step recipes without help. So on lecanemab, at 18 months, about 30% of people who were on the drug were less likely to go on to the next stage of the disease. So for example, to go from mild cognitive impairment to mild dementia. So staying stable is important because many people with mild cognitive impairment can drive independently, whereas mild dementia, it starts to become more of a concern. And so that's another way to relay the effects of these drugs. And donanemab, very similar results. About a third of people remained at the same disease stage compared to those who were on placebo. We're learning a lot now that these studies have been published for a few years, and we're trying to identify who are the groups who are benefiting the most from these drugs. And it turns out that those who have less of the tau protein in their brain, which we can measure with PET scans done in a research setting, that those are the ones who seem to have the best benefit or are most likely to be stable. So if you look at people with low tau in the brain who were treated, about 76% of people on lecanemab held their ground, did not progress at 18 months, compared to about 50% of people on placebo. So this is a group of people who have a sort of a benign course anyway, but they have even more of a benign course when they're treated. We're also looking at how we can make the drug safer. So you heard that brain swelling was a concern. Well, they've now shown that if you dose donanemab a little differently with a modification, you could dramatically make the drug safer. And this is the modification which we've implemented at Mayo Clinic. So this has led to development of Alzheimer's treatment clinics. There's one in Rochester, there's some in Minneapolis as well. And we diagnose people, and then we offer them, if they're appropriate, treatment with one of these drugs. And this is just a look at what our treatment clinic looks like. Every clinic is a little different, and we try and get people a swift answer over the course of a week. Once they know if they're eligible or not, they move on to a treatment clinic where they might get the drug every 2 weeks and get their safety monitoring as appropriate. So now I've talked about where we were, where we are, and now I'm going to talk about where we're going, because there's a lot of questions that remain. We don't know what the long-term outcomes for people who are on these drugs are because they're new drugs. We don't know the safety issues in people who develop side effects. What happens to them? We're starting to identify the people who benefit the most, but we need more data on that. We need to be able to predict who's going to get side effects and when. And we need to understand which aspects of the disease these medications are targeting other than amyloid. We also don't have a perfect way of understanding the best time to stop the drug or decrease the dosing frequency. So one of the key areas we're headed into is towards Alzheimer's prevention. So it turns out that the amyloid protein, which causes Alzheimer's disease, starts depositing in the brain 20 years before the first symptoms start. So that's quite humbling when you think about it, but it also offers this window of opportunity to target that protein before it has its toxic side effects. And so the AHEAD study, which is an NIH-funded study, is looking at what happens if we remove this amyloid protein before any symptoms start. And it's doing it in two ways. One is it's doing it in the A3 study, which is on the upwards part of the curve of amyloid. So that's when people have started to develop amyloid in their brain, but it hasn't fully saturated the brain. And then the A345 study is when people already have a whole lot of amyloid in their brain, but they have no symptoms yet. So if we can target the amyloid protein in these two populations, can we slow down or even stop the disease? And so I'm pleased to say this study is fully enrolled, and we should have some answers in 2028 whether this strategy is effective. And this is really an international study. There's, I think, 70 plus sites in the US, including ours, and international sites as well. And this is one of the most important studies in the field because it's moving from treating people once they have the development of cognitive issues to seeing if we can move earlier and prevent the disease potentially as well. So very exciting. And it was really the development of these biomarkers of the proteins that cause Alzheimer's disease that enable us to do this type of work. One of the cool aspects of this study is it was the first one to really start to use blood tests for Alzheimer's disease to enroll. So what they would do is you would give a blood, and if your levels of these proteins were at a certain threshold, you would then get the gold standard PET scan to determine whether you were eligible or not. And this is a big development for the field of prevention because before we were doing that, you'd have to scan 10 people with expensive PET scans to get one into the trial. And by using a blood test to triage, you can now cut that number down substantially. And these blood tests are now actually available in the clinic. So June of last year, we started offering blood tests for people with symptoms as a way to adjudicate whether their symptoms are due to Alzheimer's disease or not. So you can imagine how much progress has happened with the idea there's now a blood test being actively used that's accurate in the clinic. When they used the state-of-the-art blood test, they were able to identify people with amyloid in their brain with 95% accuracy. So I've talked a lot about amyloid, but that's not our only target. Amyloid is not good enough. A 30% slowing is not good enough. We need to look at other aspects of the disease to see what we can do. So a lot of people have wanted a focus on the tau protein because it's more intimately related to cognitive symptoms than the amyloid protein. And they have this study using what's called an antisense oligonucleotide, which shuts down tau production. And they've shown in phase 1 studies that you can melt away the tau in people's brain using PET scans with this drug. So it's the first time we've been able to see engagement of the target with a tau-based agent. So this study is now being, it's in phase 2. So that's the phase before it goes to phase 3, which is the definitive study. It's a little complicated because these genetic therapies have to be given into the spinal fluid space. So it's quite invasive, but still an important study nonetheless, because it's going to be, tell us whether targeting tau can have an impact on the disease course, and is a very exciting area for us. So one you may have heard of is, what about targeting a vascular component to Alzheimer's disease? So you may have heard of semaglutide or tirzepatide, which are the weight loss or diabetes drugs that you've been hearing about in the news. Well, it turned out that in observational studies of people with diabetes, when they were given these drugs, not only did they lose weight and lower their risk of heart attack, improve their kidney function, improve their sleep apnea, but they had a significantly lower risk of dementia. So Novo Nordisk, which has semaglutide, quickly put together 2 phase 3 studies to look at whether semaglutide would slow down Alzheimer's disease. And they think it may have positive benefits on inflammation. These studies actually will read out this October, so it's exciting for us to know whether these targets would be druggable, and whether targeting these other aspects of the disease process can be an additional treatment for us. Some people feel that these drugs are just targeting vascular risk factors and not Alzheimer's disease itself. So if you make people normal weight, you normalize their blood pressure, you normalize their cholesterol, their diabetes is under good control, their risk of dementia is going to be lower, because they're not going to get strokes in the brain or blood vessel damage. And so there's some controversy whether these drugs are targeting amyloid and tau themselves or the vascular component. Either way, it will be very helpful to know whether they're going to help us. There have been trials in Parkinson's disease, and they were not very effective. So one of the exciting things the Alzheimer's disease field is doing, taking a learning lesson from cancer, is doing what's called a platform trial. Because if you do each trial independently, it can take 5 years to know whether the drug works, and that's not fast enough. That's what we hear. And so what these platform trials do is they have 1 placebo arm, but 3 or 4 treatment arms. And you then have a surrogate endpoint. In this case, it's going to be tau PET, and they're going to use, in this tau platform, multiple tau-acting agents to see which of those drugs impact tau the most, and then quickly move that drug to phase 3. And so instead of taking 20 years to trial all of these medications, they're going to do it in an 18-month window and only move forward with the drug with the highest likelihood of having benefit in phase 3. So this is the tau platform. It is not open yet. It's going to open, we hope, by the end of the year, at least by 2026. And it's looking at people who are currently not receiving any treatment, and whether giving them a tau drug in addition to an amyloid drug could slow down tau uptake. And so where are we heading? So when you think about what's causing dementia, it's not just amyloid and tau, the hallmarks of Alzheimer's disease, but there's other pathologies in the brain. So one is called alpha-synuclein, which causes Parkinson's disease. Many of you are familiar with vascular disease, which is strokes or blood vessel damage. And so we really need to start taking an approach where we're targeting multiple components of dementia at the same time. And that's where we're going to get more than a 30% slowing. We're going to be able to get a 60 or even 70% slowing once we move to multiple drugs for the same person. So I'll just briefly end, and then we'll open it up for questions. So it's now clear that removing amyloid from the brain slows down Alzheimer's disease by about 30% early in the disease course. Many people feel like combination therapy is going to be necessary, meaning amyloid plus tau or amyloid plus vascular, to increase that 30% slowing. The benefits of amyloid removal may be greatest before symptoms start, and those studies are in the pipeline. There's lots of new strategies being tested. I just shared a small proportion of them. And I would just say there's lots of good resources available. The Alzheimer's Association website often has great updates on the latest and greatest trials and research happening. And with that, I'll open it up for questions. Thank you. And if we could pass the mic box around, so please go ahead. Who's first?
Yeah, with the AHEAD study, you were mentioning that there's now this blood test. Who are the candidates for that? Is it covered by insurance, or like what's the protocol for requesting testing or asking for it with your provider?
Thank you. So the question was around the new blood test for Alzheimer's disease, and it's a great question. First, I'll say not all blood tests are created equal. Just as new things are coming to any field of medicine, there's some blood tests that are better than others. The one that has the best evidence, and it's from multiple companies, is called plasma tau 217. And that one, even though it says tau in the name, actually is associated with amyloid in the brain, and it's quite accurate. And the way to use it is really at this point in the symptomatic stage of the disease. We're not recommending people who are asymptomatic get it done yet. And there are some cautions. It can be elevated in people with kidney disease. In people who are very obese, it can be lower than it should be because of volume of distribution. And so there are some caveats to using it, but we're using it as a screening for people with cognitive impairment to see whether it looks like they're on the Alzheimer's pathway or not. And I can't, we're having good luck with it being covered with insurance, but I have heard others, because it's such a new test, not having as good of luck. And so hopefully by next year, once it's been out a year, that issue won't be as big of a deal. Yeah, they keep refining these blood tests, and some of them are coming up with a panel of biomarkers to increase the accuracy. But I will caution folks that we have seen people getting blood tests that are not accurate. So the ones that are like plasma A beta 4240, for example, those don't seem to correspond well to what's going on in the brain, and that can lead to distress amongst people who are getting these less accurate blood tests. So you want to be sure to know which one is being done, and hopefully the physician ordering it would be able to talk around that.
Just a follow-up question on that. So you said you would not recommend asymptomatic people take the p-tau 217 test or the associated test. Can you tell us why? Because so my parents, actually, full disclosure, both my parents worked with Dr. Peterson, who I assume you work with at the research center. They have both since passed, but I have very warm feelings towards him and everything you guys do down there. So thank you for being here and for being there. So having both parents who have passed from Alzheimer's, I obviously have a lot of concerns about it myself. If I took this test and it said, oh yeah, you have some amyloid, or potentially you have some amyloid, that would be informative to me, I would think, and maybe help. Maybe I would change lifestyle factors or do other things. So I just want to understand that difference of, nope, it's really for symptomatic and for research purposes, versus no, anyone should maybe do this just to get that information.
That's a great question. We get asked it a lot. Anytime a test is designed, you have to think about the population it was validated in. So these blood tests were validated in people with dementia. And so the pretest probability of Alzheimer's disease is 60 to 70% in those populations. When you go to asymptomatic people, particularly you're looking at people under 70, for example, the number of people with amyloid in the brain goes down substantially. And so the accuracy, the false positives and false negatives go way up. And you could be in a position where you think you have Alzheimer's and you don't, or you think you're safe from Alzheimer's, but you're not. And so there's no data to suggest these drugs or these blood tests are performing at a rate in asymptomatic people that you would recommend that it be done, because they have not been validated in that population yet. That work's ongoing. So that's one reason I'd be cautious. The second is If you are interested in that, I think one of the options would be to get it done within the setting of a clinical trial, where then it would be validated against a gold standard test like a PET scan as well, so you know the outcome, and then there's something to do about it. You could potentially get in a trial to try and mitigate the effects if it were there. So for example, this the tau platform trial is looking at asymptomatic people with amyloid and tau in their brain. So that would be one case where we would say it'd be reasonable to consider getting it done. But because of the level of accuracy being indeterminate and the fact we don't have good treatments in that space yet, our recommendation is not to do it at this point.
She's going to ask it.
What is your thought or your experience so far with folks that are on lecanemab and having good results, and about adding in a tau drug or being a participant in a study with a tau drug? What are the kind of general thoughts these days?
Thanks for asking the question. So the question was what our experience with Leqembi or lecanemab is, and second, what do we think about adding in a tau drug to those who are on lecanemab? We're really just at the start of getting a decent number of people through the first year of treatment. Our experience has been better than we expected in terms of the side effect rate being lower. So in the papers, you would expect about a 12% rate of brain swelling, 3% symptomatic, 1% very serious. We've taken a pretty cautious approach to who we're treating. So our rate of side effects for the brain swelling is 4%. So, much lower than we would have expected based on the trials. So that's been very positive. We've also seen a number of people be surprisingly stable compared to where we thought they would be otherwise. And it's hard to say what that means because we can't look at them in parallel untreated. But I will say it's not just me. My other colleagues who see folks in our treatment clinic have been surprised. Not everyone, but a good handful of folks have been surprisingly doing really well at a year without much difference on their cognitive testing. And, we expect people to be getting worse. So I think that's been positive. So overall, positive, but it needs to be taken with a grain of salt. In terms of adding on drugs, so there's no tau drug currently available. They're only in clinical trials. Most of the trials will exclude you if you're on lecanemab already. There are some trials, because so many people are on lecanemab, it's very hard to do a placebo-controlled trial in early Alzheimer's anymore. So one of the trials, for example, that we're doing where they're taking people on lecanemab and seeing if adding a new drug can add to the benefits is called the START study. And it's taking people and it's seeing if giving a drug that rescues the synapse, which is the area between two brain cells that gets depleted in Alzheimer's disease, whether that mechanism is synergistic with lecanemab, so you can be on lecanemab or not lecanemab, and get into that study. And as we started the study last year, our first 6 people, none of them were on lecanemab. Our next 6 people, all of them are going to be on lecanemab. And so I think trials are going to have to start to change their design to accommodate this new era. And other fields of medicine like multiple sclerosis went through this, where new drugs were being approved as they were testing other trials. And so I think the answer to be specifically is right now there's not a tau agent or a trial with a tau agent that I know of that's letting people in on lecanemab, but there are trials existing that do allow lecanemab, and I would potentially look to those if they make sense.
When you mentioned, my husband had early onset Alzheimer's at 62. Clearly, I'm sure he had it a year ago, or if not, when we got tested down in Mayo. I have 3 children who are in their early 30s. When is it recommended that they get tested for what you were commenting on, and what was that test again?
Sure. So the blood test for Alzheimer's disease is plasma tau 217. We don't recommend at this point people get that test, but what we do recommend is I would follow the HEAD study very carefully, because that's the study that's going to tell us if we can prevent or slow down Alzheimer's before it starts. It'll read out in 2028. If it's positive, it'll be all over the news. You won't have to try and dig for it. It'll be on the Alzheimer's Association site. It'll be blasted everywhere. And at that point, that would change the game for you can envision a future where then, people would start getting a plasma test almost like they would get a PSA for the prostate. Because if you can catch it early enough, you can prevent the substantial downstream sequela. And so I think at this point, the recommendation is to hold tight. Let's see how Trailblazer, Trail Runner, and HEAD perform. If they're positive, then the green light's going to go on, and we're going to have to come up with guidelines for screening, which would be an amazing future to be in.
Thank you for coming to the conference. It's very helpful to us. I wondered, is it true at this point that you agree the best way for diagnosis of Alzheimer's is neuropsych testing and MRIs, or what do you recommend?
So the question is, what's the best way to get a diagnosis? And I still think a clinical examination and history are the most important parts of a diagnosis. I wouldn't use a blood test in isolation or neuropsychology in isolation to make the test, to make the diagnosis. Those are ancillary tests which we can use if we need to. So it starts with taking the history from the patient and their care partner or informant, and then deciding what tests are necessary. Often, a brain MRI is necessary to look at the structure of the brain. We may often now get a biomarker like a blood test or other biomarker to confirm that Alzheimer's is present. And then I'd say in about half of cases, we determine neuropsychologic testing is necessary. But I'll give you some examples of when neuropsychologic testing is not necessary. So once someone has moderate dementia, you wouldn't want to do neuropsychologic testing because they're going to bottom out on all the tests, and it's not going to give you information as to the etiology. But very early on, it can be very helpful. And so it just depends on who the patient is in front of you, whether you're going to use that tool or not.
I'd also like to thank you for coming, and this information is so helpful, and it gives hope, I think, to families who have been affected by this disease. So thank you for what you're doing. You mentioned some Alzheimer's treatment centers. Are those centers that are part of the Mayo system, or are there some centers out there that I'm not aware of that are dedicated just to treating Alzheimer's patients?
The question was about Alzheimer's treatment centers. So I mentioned, so we have established with these new drugs at Mayo an Alzheimer's treatment clinic, with the idea that these are just the start of the drugs that are coming. And so we need a way to deploy these drugs in a scalable manner. And so that's how we envisioned it. There's lots of centers, though, that are taking a similar course of action. I know there's, in Minneapolis, for example, Minneapolis Clinic of Neurology, now Naran, University of Minnesota just got started on theirs. And so I think there's enough buzz in the field that it's going to be quite widespread. They may have different names for the approach, but the idea is, we need to be able to treat people like, for example, oncologists can treat cancer in a high volume way that doesn't back up the system and prevent new people from getting in. And I think we're starting to see an approach around that at different centers throughout the country.
Is there anything that you do or that you recommend to mitigate risk factors for developing Alzheimer's?
So the question is, what can we do to lower our risk for Alzheimer's disease and dementia. And so what I would just take a step back. I think the most important thing is not to necessarily focus on lowering your risk of Alzheimer's disease, but dementia in general. And the difference is dementia is an umbrella term where you have memory and thinking problems and you're unable to independently perform daily living tasks, cooking, cleaning, finances, etc. And Alzheimer's disease is a specific cause of dementia, 60 to 70% of it. And so I think we should think about how can we lower our risk of dementia in general, and whether or not it's targeting Alzheimer's disease or not. So I think the basic tenets for lowering one's risk from a lifestyle standpoint are: one, getting your vascular risk factors under good control. Blood pressure is a big one. So they did a study called the Sprint Mind study where they randomized people over 65 to a systolic blood pressure, which is the top number when you get your blood pressure checked, of 140 or 120. And your risk of developing cognitive impairment, if you were aggressive with your blood pressure treatment and you targeted 120, was 20% lower. And so we used to think that when you're older, let the blood pressure run high. We don't want to give people side effects. Let it be 140, 150. But you can lower your risk of cognitive impairment by 20% if you're very aggressive with your blood pressure treatment and get it to 120. It also lowered the risk of heart attacks and strokes, and so that's an important thing to do as well. The other vascular risk factors that are associated with dementia, diabetes is a big one, as is smoking. So those would be other things that you want to target. The next area of benefit that has had quite a bit of research is on exercise. And it turns out that probably it's cardiovascular exercise that has the best benefits for brain health. Strength training is important for bone health, for fall prevention, and a whole host of things. But when you're talking about brain health, it's cardiovascular exercise. And you probably want to hit a dose of walking that's looking at 30 to 45 minutes about 6 days a week to get the benefits. When they look at people who do 3 days a week, they're not getting they're getting some benefits, but they're not getting the brain health benefits. So you want to do cardiovascular exercise, but you don't have to be doing running or sprinting or anything. It's just even a walk seems to have significant benefits. Then the third component I would mention is diet. So the diet with the most data is a Mediterranean-like diet, and that's basically eating fish twice a week, cooking and using salad dressing with olive oil, and having a handful of nuts a day, and sort of avoiding processed foods and simple carbohydrates. And the more you adhere to that, the lower your risk of cognitive impairment. There's other things that probably are less important but still have a signal. So treating hearing loss is a new one that people may not be aware of that's associated with lower dementia risk. Avoiding head injury. Air pollution is a societal issue that's associated with dementia risk and something we need to think about how we can mitigate. It's not an individual risk factor, but more of a societal risk factor. And then avoiding excessive alcohol consumption would be the other factor associated with it. So those would be some of the lifestyle factors associated with lowering dementia risk. But, and those are all important, but doing those things does not guarantee, obviously, that you won't get dementia.
I'm just curious, the people that are on the trials and it's been found to be effective, will those trials for those people keep continuing on for several years to see if that effect is prolonged, or will there be an end point? And then who do you suppose will pay for those drugs?
So if I can rephrase your question, is your question about these new drugs that I mentioned that just came out in the last couple of years?
Yes.
Lecanemab, okay. So those drugs, lecanemab and donanemab, are not in trial anymore. They're now on the market. So they're available. But the drug companies did take people who were in the phase 3 studies and do what's called an open label extension. And so now we do have 36-month data. And it becomes very challenging to understand what that means because there's no placebo arm anymore because everyone goes on the drug. But if you do some statistical modeling, it does look like those who were treated and treated earlier have benefits to 36 months. The 48-month data, they are continuing to follow folks, but we know for 36 months at least, they continue to seem to be beneficial, especially if you were treated early.
Once again, thanks for being here. With the current regime in place, do you worry about funding for some of this? I think I read that there was one study that had been going on that was quite lengthy, lots of good data, and I think it might be at risk, but I can't specifically name that study, but.
Yeah, so I guess the question is about funding. We're always worried about funding no matter what, so it's a big deal for, fortunately, I'll say Alzheimer's disease is an important issue seems to be for everyone, and so we've been quite fortunate, and you know, we were worried about funding 5 years ago, 10 years ago, because you can imagine to do these studies with all of these participants, the imaging work, the safety monitoring, it takes a lot of resources. So, you know, funding's always an ongoing concern for us.
So this is more to the basics of the trials. How do people get considered for the trials to begin with? When a trial is being introduced, do you put it out to all the neurology clinics? How does the word spread?
Great question. So one of the ways, Tasha is in the back, so she is one of our recruitment specialists. So if anyone has any questions about trials that are happening today, you know, see Tasha, she's our guru. But we have a whole infrastructure to try and get people into the trials, and it depends on what the trial's targeting, symptomatic versus asymptomatic. There's some national trial-ready cohorts that we tap into. We tap into our clinical practice. We do outreach events to talk about trials. And so, you know, we try and have relationships with people who see a large number of individuals within our catchment area. One of the challenges we've had is the older trials used to be a pill you would take. But you can imagine now we're dealing with infusions, even intrathecal injections, imaging every 4 to 8 weeks. And so the encatchment area of people who can come back for that type of degree of intensity starts to become a little smaller. And so, you know, it's become more challenging for us, especially in Rochester, to, you know, tap into enough people for some of these. Fortunately, we've been able to do it, but, you know, it's going to be an ongoing challenge to make these trials more accessible to people who want to. A lot of people want to be in them, but it doesn't make sense if you live in Duluth to come to Rochester every week, you know, for example.
We have about 15 more minutes, just to let everyone know.
Oops, I like to ask why questions, so I'm just wondering, like, why the proteins are being deposited in the brain, like, what's causing that?
Great question. So a lot of it is genetics. So 40% of Alzheimer's is thought to be due, 40 to 60%, depending on which study, is due to genetic causes. And almost all of the genes that cause Alzheimer's disease increase the amount of the amyloid protein, A-beta 42, which is very sticky, and it sort of sets up the cascade of events. So if you look at the presenilin mutations, amyloid precursor protein, all of those are increasing amyloid production. In fact, a lot of Alzheimer's research started in Down syndrome. And in Down syndrome, people have it's called trisomy 21, so they have 3 of chromosome 21, which is where the amyloid precursor protein is located. So they make a ton of amyloid, and they're all amyloid positive by 40s or 50s. And so that's one mechanism, is the increased production of amyloid. The second mechanism, which is thought to be important for people who have a late onset type, is clearing the amyloid once it's being produced. So there's some people who kind of overproduce, and then there's some people who failed to clear it. And it clears along blood vessels, and ApoE, which is another genetic risk factor for later onset Alzheimer's disease, is important in clearing the amyloid from the brain, which happens during sleep. And so it's thought a lot of late life Alzheimer's is due to this failed clearance mechanism, or it gets oversaturated. And that's why sleep has become such a big talking point in Alzheimer's disease, is because we know amyloid is cleared a lot during sleep. Is there something druggable or fixable we can do during someone's sleep to help clear amyloid? It's called the glymphatic mechanism, along the glymphatics to help that output mechanism.
I'll follow up on that one too. So some people have issues clearing amyloid, others overproduce amyloid. I've read a bunch on this subject, but there's different schools of thought. Is amyloid, and maybe tau too, an immune system response in your brain? And if so, what's it a response to? And I'm sure there's a million things. And are there ways to address those to decrease the whole immune response cycle that's causing the problem, if that's accurate?
So there's been some papers saying that certain viruses, for example, herpes zoster, or certain bacteria, are a driving force of Alzheimer's disease, and that the amyloid protein in the brain is actually trying to somehow mitigate that infectious response. There's actually quite dozens of papers at this point looking into that. There hasn't been any definite evidence of that being true yet. Certainly we're always got to keep an open mind to new things. But there's been some high impact papers looking at that in primarily animal models. There's a couple of human studies in post-mortem tissue. There's some people who are studying whether getting the herpes zoster vaccine lowers your risk of Alzheimer's disease, and they've looked at animal models and now looked at Medicare data to see that people who got their vaccine for herpes zoster seem to have a lower risk of developing Alzheimer's disease. So it is an area that's garnered some attention, but few people proposing a trial of vaccinating people with the zoster vaccine versus not, to see if they can show that more than just retrospectively.
Thank you for being here, Doctor. What research has been done on gut health?
So the question is, what research has been done on gut health and Alzheimer's disease? So there's been a lot of basic science research linking different microbiomes to and associating it with Alzheimer's disease. But they haven't gotten to the point that they've shown causation. It's more association, and so there's lots of groups that are collecting samples and trying to look at future risk of Alzheimer's disease and predicting it, and then whether you can, I have seen one trial propose to alter the gut microbiome to treat people with mild cognitive impairment, but they didn't have any preliminary data yet to really garner the funding it needed. So it's definitely lots of NIH dollars have gone towards it, but it's still more at the association stage rather than the causation stage. But there's certainly many labs that are dedicated to that evaluation.
So back to the AHEAD study. So You had said you certainly don't recommend people getting this blood test and wait till some results come. How did you identify people who were asymptomatic to be in that study? Because it's the younger people if it's been developing for 20 years prior to symptoms.
So even though it starts developing, you can't really detect it in most people until 60, 65. That's one thing. The second thing is that study was challenging to recruit for, to be honest. We were fortunate to have these trial-ready cohorts. One is called there's a website, I think it's called the APT website. Is that right, Tasha? It's called the APT website where people sign up across the country and they get a cognitive test every 12 months and enter their family history. They can give some genetics to be done, and then that will feed to our site or whatever site's doing the trial, and that gave us large batches of people. We actually used our medical record linkage system to identify people who were in the appropriate age group with a family history. We sent notifications out to them that we were doing the trial. We did events to get people in who were interested. We got people from our clinic who had a family history who were asymptomatic. So we tried all sorts of different ways to bring people in. But if you have any ideas, let us know, because more of these trials are coming, and it's very hard because even if you get a lot of people screening, you need enormous numbers still to get the right people into the trial. Because so to get, I think, 16 people into a head, we screened over 200 people. So it's a lot of effort into that. Great.
I may have missed it, but what are the costs estimated associated with this kind of research, or the cost of the medicine that would follow from it?
So the question is around the cost. I'll start with the cost of the medicine is very simple. It's about $26,000 per year for the medication. We've had pretty good success with Medicare insurance, particular covering the cost, but there are co-pays people have to pay. There's MRIs, physician visits, and so it's not just the financial cost. There's the burden of getting to the appointments, taking time off to come to the infusions for people working. So there's a huge amount of cost that's not calculated into the drug cost. So hopefully, if we get to subcutaneous injections, which they're working on, some of that will be decreased. But it is a challenge for the field that it's not just the cost of the drugs, it's the cost of time and resources that are very challenging.
You have about 5 more minutes.
Remember what my question was. Have there been times when there have been characteristics of a brain after death where clinicians would look and see, well, that person looks like they should have had dementia or Alzheimer's, but then didn't?
So the question is, are there times where we're looking at autopsy brains and the brain characteristic looks like someone should have had more pathologic change than they did? So one thing I'll say is there are some people we've seen who have carried 2 of the ApoE4 alleles, which are the late life risk factor for Alzheimer's disease. So if you have 1, your lifetime risk of Alzheimer's disease is about 30%. If you have 2, it's about 80%. So it's a high risk. And we do have some cases where people had 2 and died in their 90s with no cognitive problems. And one of our neuropathologists is interested in studying neuroinflammation. And she started to see that their, I'd say, they had a different neuroinflammatory response to the amyloid in their brain than people who developed symptoms. So the brain cell important for that is called the microglia, And they had a very different type of microglia present when they seemed to successfully ward it off. And so that would be one of those cases. Looks like we got one in the back. We'll do one more here.
Hi, I came in late, and it's good to be at the end of the session. And my mother has Parkinson's dementia, and I'm wondering how that differs from general dementia.
So the question is, how does Parkinson's dementia different from general dementia? So when we think about dementia, as I mentioned, it's really an umbrella term referring to when someone has memory and thinking problems and starts to need assistance with their daily activities, again, cooking, cleaning, driving, doing the finances. And then we look at the types of dementia. Alzheimer's is about 60 to 70% of dementia. The next most common type would be a vascular type dementia. And then after that would be a Parkinson's type dementia or Lewy body dementia, depending on what the terminology is that you use. And that is different from Alzheimer's disease because it's caused by a different protein in the brain. It's caused by alpha-synuclein that's deposited in the brain. And it has different features. Often you know about the motor features, which are associated with Parkinson's disease, but often people with Parkinsonian type dementias have more what's called fluctuations. So they have more times where their thinking's very clear, and then their thinking becomes disorganized. They have more hallucinations. They have more disturbance in their sleep. So they might act out their dreams, punch, kick, yell, or scream. And so it's a common form of dementia with different features and also will require different treatments because of that. And there's now some more clinical trials happening in that space as well. There was just a positive phase 2 study in Lewy body dementia called the SHIMMER study using a compound called CT1812, which improved cognitive function, and that's the one that I mentioned that rescues people's synapse, and we're looking at it in Alzheimer's disease in conjunction with or without lecanemab. And so there's a lot more happening in that space as well. Great. Well, thank you all so much. I appreciate your attendance.
Yes, thank you so much, Dr. Graff.